Hello everyone. In the series of this diabetes presentation, today we'll be discussing about the one of the microvascular complication of the diabetes, that is diabetic neuropathy. Diabetic neuropathy can be defined as the presence of signs and or symptoms of peripheral neurodysfunction, and such signs and symptoms are present in any patient with diabetes. And when we are sure that this peripheral neurodysfunction is not because of any other disease apart from the diabetes. In this diabetic neuropathy, there is progressive loss of neuronal function, and this progressive loss of neuronal function is due to uncontrolled and prolonged hyperglycemia. As we know that diabetes is a condition of hyperglycemia, and this diabetic neuropathy is a common complication which is found in both kind of diabetes, that is type 1 as well as in type 2 diabetes mellitus. However, when we see the lifetime risk for development of diabetic neuropathy, so it is more in type 1 diabetes mellitus as compared to type 2 diabetes mellitus. However, this diabetic neuropathy can also be seen in a person who are not a confirmed case of type 1 or type 2 diabetes mellitus, but they are labeled as pre-diabetes. Means in such condition where the level of blood sugar is higher than the normal condition, but we can't surely label them as a case of diabetes. This diabetic neuropathy has been labeled as a silent complication. Why? Because such patients of diabetes with severe neuropathy, they don't show any kind of symptoms initially, so that we can refer them for the management. Diabetic neuropathy is a condition which reduces the quality of life of any person with diabetes, and it is one of the leading cause of non-traumatic lower limb amputation in the world. Diabetic neuropathy is also a major factor for the development of hidden complications of the diabetes. Example of such hidden complication is erectile dysfunction. As in diabetic neuropathy, there is loss of neuronal function of the person. So such neuronal function loss can be involved both kind of neurons, somatic as well as autonomic, and as per their involvement, as per the kind of neurons involved in neuropathy, we can see a varied presentation as per the involvement of the nervous system affected. And sometimes this neuropathy can also involve the cardiovascular system, and it can cause sudden death. Now let's discuss what are the risk factors for development of diabetic neuropathy. So one of the most important risk factor is high level of HbA1c, which means there is poor glycemic control in a patient of diabetes. Another risk factor is smoking. Number 4 risk factor is elevated blood pressure level or hypertension is there. If any person is obese, then chances of neuropathy development is high. If any person is having any lipid disorder, dyslipidemia, in such persons also there is higher chances to develop neuropathy. It is found that the greater height is linked with the diabetic neuropathy, means if any person is with of great height of person is higher, so chances of development of neuropathy will be higher. Apart from that, microalbuminuria or macroalbuminuria presence can also increase the risk of neuropathy. As we know this, that diabetic nephropathy and diabetic retinopathy are some other also microvascular complication of diabetes. So if any person has already developed such microvascular complication, so in those patient, chances of development of neuropathy will also be increased. Now let's discuss about the pathophysiology of diabetic neuropathy. So in diabetic neuropathy, both metabolic as well as ischemic mechanism can be involved for the development of neuropathy, can play an important role for the development of neuropathy, and such metabolic and ischemic mechanisms can be alteration in the neurotransmitters, neuronal loss, any inflammation associated, any autoimmunity, microvascular damage which can cause the damage to the neurons, and presence of cells with the oxidative stress. So this pathological process of development of diabetic neuropathy can involve both kind of neurons, myelinated as well as non-myelinated neurons. And in diabetic neuropathy, it is found that there is a microvascular damage which involves the small blood vessels which supply to the neurons. It is also found that the long-standing hyperglycemia can result development of series of metabolic events which ultimately damages the vessels which supply to the neurons, and ultimately neuronal injury can be seen. In diabetic neuropathy, various pathways are involved. Some of them are polyol pathway, the cytokines, the advanced glycation end products, protein kinase C, and oxidative stress. In diabetic neuropathy, all these pathways are involved which cause degeneration of the neurons, or nerve fiber degeneration is there. Second mechanism which causes the development of neuropathy is hypoxia, means the supply of blood vessels to the neurons are very less. And for the in this pathophysiology of diabetic neuropathy, which is a result of chronic hyperglycemia, which involves various pathways, can cause decrease in neurotropic factors, sodium, potassium, ATPase, which ultimately leads to vasoconstriction and means decreased blood supply, blood flow to the neurons, and ultimately there will be decrease in the nerve conduction velocity, and ultimately this will damage to the nerves. Now let's discuss about the classification of diabetic neuropathy. So the classification of the types of diabetic neuropathy was given by the American Diabetic Association in 2017, and as per this ADA classification 2017, the diabetic neuropathy can be broadly divided into four broad categories: diffuse neuropathy, mononeuropathy, the non-diabetic neuropathies, and the radiculopathy. So in diffuse neuropathy can be of again two types: the diffuse symmetric polyneuropathy, DSPN, and second one is autonomic diffuse neuropathy. This diffuse symmetric polyneuropathy can again be divided into three categories: the primary small fiber neuropathy, primary large fiber neuropathy, and the third one mixed small and large fiber neuropathy. This autonomic neuropathy can be again divided into various categories according to the involvement of the organ and systems. It can be cardiovascular, gastrointestinal, urogenital, pseudomotor dysfunction, hypoglycemia unawareness, abnormal pupillary function. Mononeuropathy can be divided into two categories depending upon the involvement of the cranial oblique peripheral nerve. If isolated cranial nerves are involved, so this is the first category. In second category, there is isolated peripheral nerve involvement is found. In non-diabetic neuropathies, it can be of pressure pulses, it can be of type chronic inflammatory demyelinating polyneuropathy, radiculoplexus neuropathy, or it can be of type acute painful small fiber neuropathy. Radiculopathy can be again divided into three categories: the lumbosacral polyradiculopathy, the proximal motor amyotrophy, and thoracic radiculopathy. Now let's discuss about the clinical features related with the diabetic neuropathy. So in this diabetic neuropathy, there are various clinical features are found, signs and symptoms are found depending upon the nerves involved, and this it is found that approx 20 to 90% of the individuals who are with diabetes will develop the diabetic neuropathy. So let's see first to the diabetic polyneuropathy. So this diabetic polyneuropathy is the most common type of neuropathy, and the person with diabetic polyneuropathy can complain of hyperesthesia, paresthesia, and dysesthesia. Hyperesthesia means there will be increase in the sensitivity to any kind of stimulation. The paresthesia is the condition when there is an abnormal altered sensation will be found, like tingling, pricking, burning, or prickling, itching or numbness can be present. Dysesthesia is a condition when there is any unpleasant, intense, painful sensation is felt, and the person usually feel a painful burning, pricking or aching feelings are there. This diabetic polyneuropathy is most common in the lower extremities, and as when the disease progresses, the neuropathic changes are more as compared to the sensory changes. However, the sensory loss are still persist in those patients. The second category is diabetic polyradiculopathy. So in this condition, the person will feel severe pain and weakness, motor weakness along the distribution of the nerve roots. However, this diabetic polyradiculopathy is a self-limiting condition, and this diabetic polyradiculopathy can involve any thoracic, lumbar or femoral plexus. In mononeuropathy, as the name suggests, only a single nerve is involved, and this single nerve can be any cranial or any peripheral nerve, and the person will feel the signs and symptoms according to the involvement of the type of the nerve. So in this condition, the person can show some signs and symptoms. Example of such are diplopia, carpal tunnel syndrome, and Bell's palsy and others. Coming to the autonomic neuropathy. So in this autonomic neuropathy, the sympathetic and parasympathetic neurons both can be involved, and usually this autonomic neuropathy is seen in person with long standing diabetes, and this autonomic neuropathy can affect cardiovascular, gastrointestinal, pseudomotor and any metabolic systems. Now let's discuss about the sensory symptoms in the diabetic neuropathy. So these symptoms can be according to the involvement of the nerve fibers. When there are involvement of small sensory fibers, so in such condition the patient will feel neuropathic pain, in the form of burning and pricking pain, and the person will present as dysesthesia, allodynia or anhidrosis. So allodynia is a condition when any persons feel pain due to any stimulus which usually not generates the pain. For example, if any light feather touch is developing causing a pain, so this condition will be known as allodynia. And hydrosis is a condition of sweat gland when there is little or no sweats are produced by the sweat glands. Later the person will develop loss of pain and temperature sensation as well as the numbness and tingling. In such condition means the patient will feel that he is walking on a cotton wool and he is unable to feel his footwears. This small fiber neuropathy is usually more superficial and usually these are felt during the night time, they are nocturnal. However, when there is involvement of the large fibers, in this condition there will be profound sensory loss in the person and the person will develop chronic ulcers at usually at pressure points, and this development of chronic ulcers are due to the absence of sensation and repeated trauma. However, this involvement of large fiber are usually late and the person will characterize with the loss of vibration sense, loss of proprioception, loss of reflexes. Weakness and muscle wasting can also be seen in such patients who are presenting late to the diabetic symptoms and signs. Now let's discuss to the motor symptoms of diabetic neuropathy. So these motor symptoms usually they are occurring very late, and few examples of this loss of motor these motor symptoms are impaired fine coordination of the hand. For examples, the person is unable to turn keys in a slot. The patient slaps his foot while walking. There will be difficulty in climbing the stairs as well. Difficulty in getting up from the sitting posture or any lying position. Difficulty in raising the arms. These are the few examples of the motor symptoms in diabetic neuropathy. It is found that in the initial stages of this diabetic neuropathy, there will be release in the neurotransmitter, that is substance P, and this will lead to generation of the pain. However, in the later stage, there will be depletion of this substance P and it means there will be amelioration of the pain, means the pain will not be present there in the later stage. So what does it depicts? It means if there is relief of pain in the long standing neuropathy, so it is not a sign of cure, but it is a sign of worsening. Now let's discuss about the symptoms in diabetic autonomic neuropathy. So as we know that this autonomic neuropathy involves various organs and systems, so it has varied presentation in any patient of diabetes. So person will feel orthostatic hypotension, means whenever he gets up from the sitting or lying posture, he will feel some kind of weakness. The blood pressure of the person will decrease. Person can have pseudomotor dysfunction. This pseudomotor dysfunction can be manifested as a increased or decrease in the sweating pattern, and this will affect the quality of life of the person. The third presentation is resting tachycardia. The pulse rate will increase in sitting or in relaxed position, which is usually abnormal. The fourth condition is gastroparesis. It is a condition when there is paralysis of the stomach, which lead to food sitting in the stomach very long time, and ultimately which will lead to indigestion. There can be erectile dysfunction in such neuropathic person also. Person can have hypoglycemia unawareness, constipation can be there. Hyperhidrosis or anhidrosis means there will be increased sweating or decreased sweating can be there in a person. Urinary retention can be presented by the person, and the exercise intolerance can also be there in such persons. So, what are the methods to diagnose this diabetic autonomic neuropathy condition? So, usually we use standard electrophysiological testing to diagnose this DAN condition. In this, we record heart rate variation during the various position, as well as postural fall in the systolic BP. Apart from that, there are few newer methods nowadays to diagnose diabetic autoneuropathy, which are skin punch biopsy, the quantitative sensory testing, electrophysiological imaging studies, and corneal confocal microscopy. So, what are the treatment for this diabetic autonomic neuropathic condition? So, usually the treatment of this diabetic autonomic neuropathy is symptomatic, and this treatment will depend upon the organ and system involved in this condition. For example, for gastroparesis, which can give the prokinetic drugs. For condition of constipation, stimulant laxative can be given. For diarrhea, medications like loperamide, codeine can be given. For neuropathic bladder, manual blood pressure application can be done, or intermittent self catheterization can be done. For erectile dysfunction, the drugs like sildenafil can be given. Apart from that, few other methods are there, like intracavernal injection of vasoactive agents, the vacuum tumescence devices, etc. For gustatory sweating, medication like Pauldine, glycopyrrolate, clonidine can be given. This gustatory sweating is a condition when the sweating occurs in the person in his forehead, scalp, neck region, upper lip, and this sweating is usually felt during the eating, talking, or thinking about any food. So, what are the complications which can be present in diabetic neuropathic condition? So, the first and most common is the foot ulceration. The second one is the Charcot neuroarthropathy, and the third one is the unsteadiness, which can lead to the falls and fractures in the person. So, this Charcot neuroarthropathy is a chronic, devastating and destructive disease of the bone structure and joints, in which is usually present in a patient with the neuropathy, and it is usually characterized by the painful or painless bone and joint destruction. Coming to the screening and diagnosis of the diabetic neuropathy. So, any patient with type 2 diabetes mellitus, always screening for the diffuse symmetric polyneuropathy can be done, and whenever the person is diagnosed with type 2 diabetes mellitus, this screening should be done, and after that the annual screening of the person with diabetes should be performed for the diffuse symmetric polyneuropathy. If any person is diagnosed with type 1 diabetes mellitus, in such person also screening for DSPN should be done, and this screening should be done at the 5 years after the diagnosis, and after that we should continue screening annually. If any person is diagnosed with the pre-diabetes, in such condition also the screening should be performed if any person is showing symptoms of the peripheral neuropathy. The referral to a neurologist can be done in following condition. If the involvement of motor neuropathy are extensive as compared to the sensory neuropathy, and the onset of symptoms of the neuropathy are very rapid, or if the person is presenting the symptoms or signs of neuropathy in asymmetric manner. So what are the tests for evaluation of the diabetic neuropathy? The first one is pinprick and temperature sensation evaluation neuropathy, and this is to evaluate the function of the small fiber. This pinprick test is used to assess the perception of the pain, and in this pinprick test we usually check two variables. The first one is ability to feel a pinprick, and the second one is ability to determine the difference between the sharp and dull pain. Coming to the second test, that is 128 Hz tuning fork test, and it is usually to evaluate the vibration sense, and which is a function of the large fiber. And so this 128 Hz tuning fork test is used to assess the peripheral neuropathy by comparing how long the patient detects the vibration in comparison with the examiner. If the examiner feels vibrations longer than the patient, it means that the vibration perception of the patients are decreased. The third test is the 10 gram monofilament test, and it is to evaluate the function of the large fiber. This 10 gram monofilament test is also known as Siemens Weinstein monofilament examination, and this 10 gram monofilament test or SWME involves 3-step sequence. In first step we touch the skin, in second stage we bend the filament, and in third stage we lift the filament from the skin, and the fourth test is to assess the proprioceptive sense. Now coming to the screening and diagnosis of a case of diabetic autonomic neuropathy. So this screening will include the signs and symptoms of the cardiac autonomic neuropathy, especially in the patients who are having hypoglycemia unawareness, which is also a presentation of the diabetic autonomic neuropathy. And the diagnosis of this diabetic autonomic neuropathy is made by the obtaining the medical history from the patients as well as from the caretaker, so that we can understand any recent illness or condition which may cause alteration in the insulin requirement or dietary changes of the person. Apart from that, we need to do the physical examination of the person to assess the condition of the dehydration and any neurological sign present in the patient. In diabetic autonomic neuropathy, the screening and diagnosis can also be done by the recording the sign of and symptoms based on the system involved. For example, in cardiac autonomic neuropathy, the person can present with the resting tachycardia, non-dipping or reverse dipping of the BP. Person can have orthostatic hypotension, the orthostatic tachycardia or bradycardia, and exercise intolerance. In gastrointestinal neuropathy, person can present with the gastroparesis, diabetic diarrhea, esophageal dysfunction, constipation. In urogenital neuropathy, there will be bladder dysfunction, urinary incontinence and dribbling, sexual dysfunction. In pseudomotor neuropathy, there can be dryness of the skin or abnormal sweating pattern. To differential diagnosis the diabetic neuropathy, we need to differentiate it from various other health conditions like some congenital conditions, traumatic or inflammatory conditions, the neoplastics condition, metabolic and endocrinal disorders, the vascular or toxic events, or any autoimmune diseases. These are the list of such health conditions, illness or diseases from which we need to differentially diagnose the diabetic neuropathic conditions. Now coming to the management of diabetic neuropathy. So if the person present the diabetic neuropathy condition in a painful manner, in such condition we need to use of few medications like amitriptyline, GABA, the gabapentin, the opioids, some topical agents like capsaicin, and as per the American Diabetic Association recommendation, we can use the medication like pregabalin, duloxetine, gabapentin as the drug of choice for the initial therapy of diabetic neuropathy which are painful. Whenever we are using any tricyclic antidepressant and opioids, in such condition we need to be very cautious for the development of risk of addiction and other side effects. If any newer drugs which are targeting the pathogenic mechanism, in such condition the standardization is still required for the use of these newer drugs. Benfotiamine can mitigate the vascular damage. The aldose reductase inhibitors can prevent the accumulation of the products of the polyol pathway. Supportive therapy is required in any condition of the ulceration or Charcot neuropathy. If any patient is having disturbance in the gait and the imbalance, so in such condition we also need to give some intervention so that we can prevent the falls and the injuries like fractures. In case of orthostatic hypotension, the person is advised to do the regular exercise, and in such condition the volume repletion is also required. Low dose fludrocortisone and alpha adrenergic agonist like midodrine can also be given in such patients. If the person is having gastroparesis, then short term metoclopramide can also be recommended to such patients. Now coming to the preventive methods for the diabetic neuropathy. If in case of any person with type 2 diabetes mellitus, so it is found that the many patients with type 2 diabetes mellitus will develop diabetic neuropathy despite the glycemic control. However, such kind of patient should be advised to intensive control of the glycemic level. In type 1 diabetes mellitus also, the person is required to the intensive glycemic control, as it is found that such control can reduce the risk of diabetic neuropathy in such patients. The next method is lifestyle modification, which includes the regular exercise and dietary modification, which can also lead to reduction in the risk of diabetic neuropathy. Apart from that, there are some other measures to reduce the risk of diabetic neuropathy, which includes the treatment of the conditions like lipid disorder, dyslipidemia, the cessation of the smoking, and adequate foot care. Thanks for watching this video. If you have liked this video, please share this with others.